Good evening, everyone. So we welcome all for the August 2024 session of Journal Club and Journal Camp. We have a very important topic today, and the Journal Club topic today is impact of cytogenetic abnormalities as to how it impacts the risk of disease progression in those patients with solitary bone plasmacytomas. We do come across plasmacytomas in our daily and routine practice, but it is difficult to discern as to which ones do actually progress and which ones actually do not. So this is a very relevant article for us. And to present that, we have Dr. Vijay Bhoti. He is an assistant professor at Cancer Institute, DR, Chennai. This will be followed by a discussion moderated by national faculty Dr. Nikita Mehra and our esteemed international faculty Dr. Shaji Kumar sir. So I welcome Dr. Vijay Murthy and over to you.
Thank you, sir. I'm sharing my PowerPoint.
Not visible yet.
My slide visible, sir?
Not yet. Yes.
Now, sir?
Yes.
Yeah.
You're
Yeah, we
sharing
can
the
see.
screen, but slides are not there. Yes. Can put it on full mode. Yes.
Sir, is it visible now, sir?
Yes, looks good.
Yes.
Yes.
Yes. Good evening, everyone. Before we go to the presentation, I would like to thank the organizers and Nikita ma'am for giving this opportunity to present a very important study which has been published in a Blood Journal November 2023. The study is about the impact of cytogenetics in disease progression in solitary plasmacytoma. The study was conducted by Dr. Udit Yadav, Dr. Shaji K. Kumar and his team, and in Mayo Clinic. This is going to be the outline of my presentation. First, we will see about the background of solitary plasmacytoma and what is the significance of the study. Then we see about the methodology and the results of the study. Then we discuss about the pros and cons and what are the future opportunities based on the study we'll be discussing in detail. So solitary plasmacytoma is one of the rare plasma cell disorders which has been classified into extramedullary or bones plasmacytoma. So solitary bone plasmacytoma is defined as a single mass of clonal plasma cells with or without marrow involvement, without any myeloma features. So the current standard of therapy for solitary plasmacytoma is a local therapy in the form of radiation, which is around 40 to 50 gray with or without the surgery, followed by the close observation. So why this study is very important? It is because with the current standard of therapy, around 50% of the population is going to progress to myeloma in next 5 years, whereas around 60 to 80% of the population will progress to myeloma in 10 years. So is current standard of care is optimal in treating solitary plasmacytoma? Definitely no, because as we discussed, more than 70% of the patient is going to develop to solitary plasmacytoma. So how can we improve the outcomes in solitary plasmacytoma? Before we see the outcomes, whenever we talk about outcome, we talk about overall survival and PFS. Whereas in this, the important outcome is time to progression to the myeloma. It will be is an important factor in to improve the outcomes in solitary plasmacytoma. So there are various strategies has been used in the form of to improve the outcome in solitary plasmacytoma. One is role of adjuvant therapies in solitary plasmacytoma. We all know solitary plasmacytoma is a localized disease, but is it really localized? Because 70% of the population is going to develop myeloma. In such case, it definitely requires some amount of systemic therapies. There are various studies has conducted to analyze the role of systemic therapy in solitary plasmacytoma, which has produced controversial results. But most of these studies has conducted in all the patients. There is no risk stratification, like because Still, 40 to 50% of the population may not develop to myeloma. Is it worth treating such patients? So this study mainly aims to fill these gaps and try to address the high risk
Seven options.
solitary
ये तो
plasmacytoma.
option start हो जाएगा. No, while the
Yes. So there are various risk factors for solitary plasmacytoma. This was based on the previous study. They have found minimal marrow involvement, presence of abnormal serum-free light chain ratio, and persistent M spike after radiation therapy or any high-grade angiogenesis is considered as a risk factors for shorter time to progression. And there are few studies that assessed cytogenetic fish in extramedullary plasmacytomas, which did not find any association with the risk of progression to myeloma. At present, there are no studies have evaluated the baseline cytogenetic abnormalities by fish in solitary plasmacytoma and their impact in risk of progression to myeloma. Methodology. The study was carried on Mayo Comprehensive Cancer Clinic from data from 2000, January 2012 to December 2022. The EMR record was analyzed for this. The patients before January 2012 was excluded mainly because they did not have the advanced cross-sectional imaging, bone imaging was not available before that period. So the inclusion criteria are all the patients should have the biopsy proven plasmacytoma arising from the bone, and they should have advanced cross-sectional imaging in the form of PET scan or CT scan or a whole body MRI or FDG PET should be available. And the bone marrow biopsy also by aspirate and biopsy should be available. And the inclusion criteria mainly contains the plasma cells less than 10% of the plasma cells will be considered for inclusion. And the patients with amyloid light chain disease, Poem syndrome, multiple myeloma, smoldering myeloma, or plasma cells more than 10. Bone marrow samples, plasma cells were isolated by using cytoplasmic immunoglobulin assay or cell sorting methods. So cytoplasmic immunoglobulins, they used CD38, CD19, CD138, or cytoplasmic kappa lambda for isolating the plasma cells. And more than 1% of the plasma cells were deemed satisfactory for the fish analysis. And the paraffin embedded tissues from the bone, in that the plasma cells were targeted using H&E stain, and they were being targeted for fish test. For level of detection, 6% is required for dual fusion probes, and for break apart probes and tetraploid clones, 10% of it is required, and for TP53 on 1Q abnormality, 20% of is required for detection levels. So as per IMWG criteria, deletion 17p, translocation 1416, translocation 414, 1Q gain, and translocation 1420 were defined as high risk cytogenetics. So out of 1,138 patients, 114 patients were eligible for the study. Out of 114, only 36 patients had a baseline fish were available. So remaining 78, 19 patients, fish was performed retrospectively. So 36 plus 19, around 55 patients had baseline fish performed on bone marrow or in the paraffin embedded SBP specimen. So the results were described in three formats. One, they have described the baseline characteristics, and second one, what are the factors which has influence on time to progression from solid plasmacytoma to myeloma, and the impact of fish on time to progression. So these are the baseline characteristics. The median age of the population was 60 years, and most of the patients were white. And using FDG PET, they found the median SUV was around 6.5, and all the patients received radiation, and the median dose was around 45 gray. And 21% of the patient received underwent surgery for either for diagnostic or for palliative purpose before starting the radiation. And out of these 114, as we discussed before, 55 patients had detectable clonal plasma cells. So these clinical variables has been compared with the high risk or the standard risk cytogenetics. So among the age, sex, and race, only size and the minimal marrow involvement has a significance. Like that is, the patients whose size is more than 5 centimeter of plasmacytoma are associated with high risk cytogenetics, and the patients who had minimal marrow involvement has high risk of high risk cytogenetics. And 11 patients had deletion 17p, and 13 patients had 1q gain, and only a small proportion of patients had 414 and 1416 translocations. So what are the factors which influences the shorter time to progression from myeloma to solitary plasmacytoma to myeloma is, one is abnormal FLC ratio, and they have found 55% of the total populations progress to myeloma with a median time to progression of 37 months. And the patient with abnormal solitary FLC ratio had time to progression of 27 months, was um, median time to progression was not reached in the patient without abnormal FLC, which is statistically significant. And among the patient with minimal marrow involvement, the patient who had minimal marrow involvement has a time to progression of 21 months, whereas 53 months in the patient who does not have the minimal marrow involvement, which is also statistically significant. The studies did not find any significance in size, whether the size is more than 10 centimeter or less, which did not have any significance in time to progression. And the most important aim of the study is what is the impact of fish, high risk fish in time to progression. So among the 55%, 22 patients had high risk cytogenetics. So out of 22, 20 had progressed to myeloma. And compared with 50% was progressed to myeloma, the patient with non-high risk group. And medium time to progression is only 8 months with the patient with high risk fish, compared to 42 months in the patients with non-high risk fish, with significance of p-value less than 0.003. So among the high risk cytogenetics, we can clearly see the patients with the 17p deletions had a very short time to progression of 6 months, and patient with 1q gain has 13 months of time to progressions, which is compared to 41 months in patients who do not have either of these mutations. They have also conducted the multivariate model. In this, they have compared abnormal FLC ratio, minimal marrow involvement, and presence of high risk cytogenetics. They have clearly found only high risk fish cytogenetics has the significance independent of minimal marrow involvement and abnormal FLC ratio. So this is again the summary of the results. They have shown that around 40% had high risk cytogenetics. They had only 8 months of time to progression compared to 42 months in patients who did not have high risk fish. And the multivariate analysis clearly showed only high risk fish was significant predictor of shorter time to progression. So, what are the pros? This study is the first study to assess the clinical value of fish in solitary plasmacytoma. There are previous studies which was conducted on smoldering myeloma and multiple myeloma, whereas this is the first study to conduct in solitary plasmacytoma. Based on the study has clearly shown that high risk fish cytogenetics significantly increases the risk of progression to myeloma. Hence, the study strongly supports the performance on fish on the patients who did not have less significant plasma cells in the marrow. It warrants to do fish on the plasmacytoma specimen. However, the study also has some limitations. The study is basically a single center retrospective study. And when we go through the other studies, the most important risk factors for developing myeloma is achieving the complete response after the local therapy. The study did not analyze the any association between the CR rates and the high risk fish cytogenetics. And another important risk factor is M protein persistence after the local treatment, also has not analyzed in the study. Another important challenges is validating fish in plasma in solitary plasmacytoma. Different centers will be challenging. The study was concordant with other studies that the more than half of the patient progressed to myeloma in with a median follow-up of 53 months. And the study also has in concordance with the patient who had abnormal FLC and minimal marrow involvement has a more risk of progression to myeloma. However, the study did not observe the size as correlated with the time to progression with myeloma. However, they found the size more than 5 centimeter is associated with high risk cytogenetics. So the implication of the study is a very is a potential to change the practice. It strongly recommends to do FISH at the time of diagnosis to predict the outcomes in solitary plasmacytoma. Based on this study, there are various trials can be conducted to address whether any role of adjuvant therapy targeting the high risk cytogenetic patients, whether do they have whether can we improve the outcome in such patients. That's it. Thank you.
Dr. Nikita and Dr. Shaji, sir.
So, Dr. Vijay, thank you for the eloquent presentation. You very nicely talked about the role of or the role of adjuvant therapy in solitary bone plasmacytomas, and of course, like you mentioned, it has been controversial. Some studies haven't really shown benefit with the addition of adjuvant chemotherapy, but more recent studies do show that adjuvant therapy probably does have a benefit. It probably does reduce the progression to multiple myeloma. Shaji sir, can we begin with some questions that we can ask you with regard to?
Yeah, for sure. Absolutely. No, I think thanks again, Vijay, for the nice presentation.
Thank
You
you,
know,
sir.
again, the biggest challenge for all these is the small numbers from all these studies, right? So one of the obviously we started with 114 patients, but we only have data on 55, just less than half of those patients. And we know that presence of, marrow involvement, the solitary plasmacytoma without and with minimal marrow involvement have very different outcomes. And it's not something that we can explore within this data set, because the fact that one of the reasons the 55 patients were included in that cohort is because they had fish either in the marrow or in the plasmacytoma, which means if you had it in the marrow, you automatically fall into the solitary plasmacytoma with minimal marrow involvement. So it becomes difficult. I think you almost literally have to think about that as two distinct groups. I'm not even sure they are biologically a continuum. They could very well be two distinct entities. And we literally have to think about it as prognostic factors might behave differently within those two subgroups.
This paper really takes me back to another wonderful paper of yours that was titled The Multiple Myelomas, where you'll talk about different groups of multiple myelomas. Is it possible that this group of plasmacytomas with high-risk cytogenetics sort of forms a continuum within those high-risk multiple myelomas? I mean,
I think so. Again, I think a lot of the high risk abnormalities that we are talking about here, especially the 1q and the 17p, are all secondary abnormalities. And one other thing that we clearly couldn't look at it here is the comparison between what we find in the bone marrow versus what we find in the plasmacytoma. There are studies that have shown, mostly in the setting of extramedullary disease in patients with myeloma, where you have a higher proportion of or the fish is more likely to be positive for 17p and 1q in the extramedullary tissue compared to what you find in the bone marrow. Similarly, we have done some studies which have shown that the RAS-RAF mutations are much more prevalent, as well as mutations involving some of the genes associated with addition molecules and so on and so forth, may be differential in these two. So I think it's that continuum, right? So one hand, we have solitary plasmacytoma with absolutely nothing in the bone marrow, which we know in very small numbers can progress to myeloma. And then you have the one in between, which is the solitary plasmacytoma with marrow involvement, where the risk of progression is substantially higher, which I think is within that spectrum of myeloma. And then you have the patients who present with newly diagnosed myeloma with a extramedullary disease. So essentially and then you